And so it's my great pleasure. I'm Marcus Bosenberg. I'm one of the co-leaders of the Cancer Immunology program, and we're actually have our full house of program co-leaders in person as we speak. So today's grand round speaker will be David Braun, who's an assistant professor in the Department of Medicine and also has appointments in pathology and urology, and is a Lewis Goodman and Alfred Gilman Yale Scholar. So he is also a member of the Center for Molecular and Cellular Oncology that Marcus Muschen leads at the Yale Cancer Center, and received his PhD in computational biology at NYU and his MD at Mount Sinai, and was a resident in Boston and a fellow at Dana-Farber prior to coming here. And we're very glad he's come to Yale. So David, as you will see, is covering a remarkably broad set of things related to cancer immunology, really focused initially on renal cell carcinoma, but we'll see where that goes. And we're super happy to have him here and have him associated with the Cancer Immunology program. And David, without further ado, we'll have to start.
That's perfect. Thank you so much for the incredibly kind introduction and for the chance to speak to you all here today, and for all the people on Zoom as well. And so what I'm going to talk about today is some of the determinants of effective anti-tumor immunity in kidney cancer. And as Marcus mentioned, a lot of this is relevant specifically for kidney cancer, and I see patients with kidney cancer at SMILO, and so it's relevant for these patients specifically. But I hope as well that this can be used as a broader model of human tumor immunology, that we might be able to learn particular immunologic mechanisms that might be applicable to other cancer types as well. Here are my disclosures, not relevant for today's talk. And so I usually like to start off with just a couple of patients just to highlight the challenges within kidney cancer. This is going to be true for a lot of solid tumors, and particularly in the immune therapy era. So the first patient, these are two of my patients from the last couple of years. The first patient was a 68-year-old gentleman, a fairly common age for kidney cancer, had metastatic clear cell kidney cancer. That's the most common, thank you, the most common histologic diagnosis of kidney cancer. And had pretty widespread metastatic disease throughout the lungs. Lungs actually had a brain metastasis, and so received a standard first-line combination of checkpoint inhibitors, nivolumab and ipilimumab. And for those that don't look at CTs every day, the primary tumor is outlined in red, and we can see compared to prior to therapy, there's a tremendous shrinkage of that primary. There's basically resolution of all metastatic disease. The residual primary was resected. And so this patient is free of disease, potentially cured of their disease, has now been off therapy for over a year. That's in sharp contrast to a very similar patient, very similar demographic, received the exact same therapy for the exact histologic diagnosis. But unfortunately, the tumors did not respond to therapy. They all grew. And despite this and subsequent lines of therapy, the patient passed away within 8 months of diagnosis. And so it's cases like these extreme response phenotypes, the sort of promise of longstanding durable responses and resistance that sort of drives the questions in my lab. And there's some peculiarities to kidney cancer that on the scientific front has also been really interesting and fascinating. So historically, we think of CD8 T cell infiltration as being a positive thing, a positive prognostic thing. They're a main effector cell for anti-tumor immunity. So having a lot of them in the tumor is positive. The historical exception is really kidney cancer, where over time of the past 20 years or so, having a high degree of CD8 T cell infiltration has been associated with a worse prognosis, really in contrast to just about every other solid tumor type. Further, when we think of what are tumor types that are typically responsive to immune checkpoint inhibitors, we think of tumor types that are on the far end, the right end of this mutation spectrum. That makes a lot of sense. We have tumors that have high mutation burdens, lots of neoantigens, so lots of potential antigenic targets for the immune system. They're potentially more likely to respond. So melanoma, non-small cell lung cancer, urothelial cancer, MSI high colon cancer. And then we see right in the middle is clear cell kidney cancer with a modest mutation burden, pretty similar to glioblastoma or pancreatic cancer, or ovarian cancer. Yet both historically and contemporarily, it's responsive to immune therapy. And so my hope is we might be able to learn a little bit about why. If we can figure out why this is responsive to immune therapy, maybe we can apply those lessons elsewhere. And then also for those patients who aren't lucky to benefit from immune therapy, the current forms of immune therapy, can we understand mechanisms of resistance that can guide rational combinations of future therapies? And so the framework that our lab really uses to answer these questions, what are the infiltrating immune cells and what are the antigenic targets in kidney cancer is a pretty simple framework. And I've sort of outlined it here, where we have a tumor cell, the kidney cancer cell, interacting with an infiltrating T cell. And that takes place in the context of a heterogeneous microenvironment. And so with this really basic sort of worldview, we can begin to ask focused questions. And these are really the questions that end up guiding a lot of the projects in our lab. So the first is, what are the genetic alterations in kidney cancer? How do they potentially impact immune infiltration into the tumor? And ultimately, how do those intersect or interplay to impact therapeutic response? What are those other immune cells within the tumor microenvironment? How do they interact with T cells and impact T cell phenotype? And finally, when everything goes right and T cells are capable, CD8 T cells are capable of recognizing the tumor and eliminating it, what is it that it's recognizing? And so we know that at the heart of this interaction of antigen-specific immunity is the tumor cells presenting antigenic peptides on MHC class I molecules being recognized by the cognate T cell receptor. And for kidney cancer and for most other, I would say, solid tumors, we don't actually know what those antigens are. We know sometimes for high mutation burden tumors, those can be classic neoantigens, but for things that are modest mutation burdens, tumors like kidney cancer, it's much less clear. And so these are the sort of three fundamental areas that the lab is currently working on. And we'll kind of step through each one, maybe talking a little bit about some prior work over the last couple of years when I was back in Boston, and then some ongoing efforts now in the lab. So the first is really, what are the mutations in kidney cancer that might impact immune infiltration and ultimately response to therapy? And I would say broadly, we use a lot of classic genomic techniques, whole exome sequencing, RNA sequencing, to really approach these questions. And so a lot of the motivation for this came from an early study just a few years ago from Ellie Van Allen's group at Dana-Farber, where he looked at a small phase 1 trial of nivolumab in kidney cancer, the Checkmate 009 trial. And it was only about 35 patients that had genomic data available. But for those 35 patients, asked a pretty simple question. What are the mutations that are recurrent in kidney cancer among those 35 patients? And out of those recurrent mutations, and that's on the x-axis, and out of those recurrent mutations, which are actually significantly impacting response to therapy? And that's on the y-axis. And we can see there's only one. Loss of function mutations in the PBAF complex member, PBRM1, was associated with improved response. And we see at the bottom also improved survival in this small cohort of 35 patients. So really building off of this initial finding, we were, through partnership with Bristol Myers, able to sequence not only the phase 1 data, but the tumors from the phase 2 and phase 3 trials of nivolumab in kidney cancer. And looking specifically at the phase 3 trial, which is the Checkmate 025 trial, we were able to confirm that, yes, loss of function mutations in PBRM1 were associated with improved response, and in this case, progression-free and overall survival with nivolumab with immune therapy, though we can see the effect size is fairly modest. So it's really, it's something that's there, but is certainly not the whole picture. And so this was a very focused sort of validation question, but we really want to look at this much more comprehensively. And so what we did was, again, in partnership with Bristol Myers, we're fortunate to have access to tumors from the phase 1, phase 2, and phase 3 trials of nivolumab in kidney cancer. The phase 3 trial is really the pivotal trial that led to the first checkpoint inhibitor approval within kidney cancer. And we're lucky to benefit as well from that phase 3 trial also having a control arm, an mTOR inhibitor, everolimus. And so we could see if there's anything that we find that might be associated with response or resistance. Is that something that's specific for immune therapy, or is that something that's perhaps more prognostic that we see with all therapies, including one with an independent mechanism of action like an mTOR inhibitor? So we performed whole exome sequencing, RNA sequencing, and CD8 immunofluorescence to really look at the immune infiltration, the broad immune phenotype of these tumors. At the time, this was the largest study of genetic study of advanced kidney cancer. The TCGA, which was really a foundational work, really skews towards earlier stage tumors. Only around 10 to 15% of the kidney cancer tumors in TCGA are advanced stage. And so by sequencing this, we can really get an understanding of first the genetic landscape of advanced kidney cancer. And there's some interesting findings in here, some enrichment in clinically unfavorable aggressive mutations and copy number variants, things like NF2 mutations, a loss of 9p21.3, but really our primary question was, how does this ultimately impact response to immune therapy? And so the first thing we did was look at some of the classic markers of somatic alteration burden that is present in that we associate other tumor types response with. So we know that there's a histology agnostic approval for the immune therapy drug pembrolizumab based purely on mutation burden. And we know that in many tumor types, there's an association with high mutation burden response to therapy. And so for kidney cancer, we looked at total mutation burden, we inferred neoantigen load, we inferred neoantigens derived from frame shift insertion deletions, which create new open reading frames, and no metric of somatic alteration burden was at all associated with response. So again, this is in sharp contrast to melanoma and some non-small cell lung cancer and bladder cancer. Here, mutation burden really does not associate or predict response to therapy. When we then looked across each individual recurrent mutation and tried to see which one might be associated with resistance or response in this much expanded cohort, again, we found only one. In this pooled analysis, it was only PBRM1, which is a very common mutation present in perhaps up to 30 to 40% of kidney cancer tumors that was associated with improved response and overall survival. And again, here we really could benefit and see that this response, this impact on response and survival was unique to the patients treated with immune therapy and was not seen in patients treated with the control arm with an mTOR inhibitor. So that's mutations. What about the immune landscape and how that might impact kidney cancer? We know that prognostically, having a lot of CD8 T cells might be a negative thing, but how does that impact response to immune therapy? And so the first thing we did was characterize these tumors broadly into 3 immune phenotypes. And these are types you might be familiar with: the classic immune infiltrated, where there's lots of CD8 T cells, immune deserts, where there's a paucity of CD8 T cells, and then immune excluded tumors, where there's perhaps lots of CD8 T cells lining up to the tumor margin, but really unable to infiltrate the tumor center and have effector function. That's a potential mechanism of resistance in other solid tumor types, including a common mechanism of resistance in bladder cancer. And so when we looked at our kidney cancer tumors, our advanced kidney cancer tumors, the first thing we observed was that immune exclusion is really not a common phenotype. It's not looking to be a predominant mechanism of resistance in kidney cancer. We see here only about 5% of these tumors are immune excluded. This is in contrast to something like bladder cancer, where up to 50% of metastatic bladder cancers might have this immune exclusion phenotype. The other thing we can observe is, by and large, these are heavily CD8 infiltrated tumors. About 3/4 of these tumors are highly infiltrated by CD8 T cells. But again, in contrast to a lot of other solid tumors where having a lot of CD8 T cells might positively impact response, here it had no impact on response and survival. And we can see that for patients that I'm showing here treated with immune therapy, that regardless of whether you had an immune excluded tumor, an infiltrated tumor, a desert tumor, all of those had roughly the same response to therapy and survival. And so looking at genetics alone, didn't yield much. Looking at the immune phenotype alone really doesn't tell us which tumors are responsive to therapy. Is there perhaps some interaction or interplay between them? And so the first thing we did was really just look at, among the infiltrated or non-infiltrated tumors, are there different mutational landscapes? Are there different driver mutations that might be present in one or the other? And the answer was yes. And here again, it was only one, that it was actually the immune desert tumors, the ones that lack CD8 infiltration, that were really enriched for these clinically favorable CD8 T cells, that nearly half of those immune desert tumors had mutations in PBRM1, whereas less than 1/4 of the immune infiltrated ones did. So among mutations, we have enrichment of clinically favorable PBRM1 mutations within desert tumors. How about within infiltrated tumors, particularly looking at copy number alterations? And here there was a different picture. There was actually a lot more copy number alterations within these infiltrated tumors, potentially indicating these might be perhaps more chromosomally unstable, having a higher copy number burden in general than non-infiltrated tumors. And so we took a similar approach. We looked systematically which copy number alteration was associated with, was increase in infiltrated tumors, and that's on the x-axis. And then out of those infiltrated tumors, which copy number alteration might be associated with altered response or survival, either positively or negatively, and that's on the y-axis. And again, only one came out, deletions of 9p21.3, which contain genes like CDKN2A, CDKN2B, MTAP, single copy loss of 9p21.3 was associated with worse survival and worse response. And looking at whether this effect was really specific to anti-PD-1 treatment or a broad prognostic effect, we could see that really loss of 9p21.3 within these infiltrated tumors was associated with worse progression-free and overall survival, really only with anti-PD-1 treatment with immune therapy on the left, and not with mTOR inhibition, a control arm shown on the right. So what is it that's impacting this response? Well, how is 9p21.3 actually acting to lessen response to immune therapy? That remains an open question. We took a first look at least some activated pathways by integrating the RNA-seq data and really looking at which pathways might be enriched in these 9p21.3 tumors. And there's some potentially initial hits. There's certainly more angiogenesis and hypoxia on those tumors. There's definitely more increased mTOR signaling. And so at least some initial hints as to how these might be associated, but there's a lot of mechanistic work that still needs to be done. And so the initial model we put forward for this is that, yes, in theory, CD8 infiltration should be associated with better response to PD-1 therapy, just like in other tumors. But what we have here is overlying the genetics of the tumor. These infiltrated tumors are enriched for loss of function PBRM1 mutations, these clinically favorable mutations that bring the response rates up. And the infiltrated tumors are enriched for these clinically unfavorable deletions of 9p21.3, and again, dragging the response rates down. And so this is the work that was done now, published a couple of years ago. And while at the time this was a large sequencing effort, it was about 454 tumors that underwent whole exome sequencing, it turns out that that is only enough to capture essentially fairly common mutations in kidney cancer that might be associated with immune infiltration or response, that you actually need much, much larger numbers to really saturate and really get a better sense of the full landscape of genetic alterations within kidney cancer. And so in efforts that we're leading together with Ellie Van Allen's lab, we've put together now a cohort of just about 2,000 patients that were treated with immune therapy. This is from a series of phase 3 trials, including that Checkmate 025 trial, but other more modern combination therapies, phase 3 trials of pure immune checkpoint inhibitors like nivolumab plus ipilimumab, or immune therapy plus anti-angiogenic inhibitors. And the reason we're doing this is sort of demonstrated by this simulated power calculation, which I've shown here, which is basically for the number of patients we have in our cohort, which is shown on the x-axis, what frequency of mutation are we actually powered to detect? So if we look at our original paper from a couple of years ago now, we were actually powered to detect exactly what we found. Things that are really quite common in this case, PBRM1 mutations was present in nearly half of responsive patients and a little bit less than a quarter of non-responsive patients. Very, very common mutations. That's all that we were powered to detect. Now that we have a much more substantial cohort of over 2,000, out of which about 1,500 were treated with immune therapy, we're now powered to detect a much broader range of mutations that might impact response or resistance, things that might be present in as low as 5% of responders. And so really getting a much broader idea of the genetic alterations and how they might be associated with resistance. And so our sort of questions driving this project are, one, just about kidney cancer genetics. What are the long tail of mutations? We know the most common mutations from TCGA, but what are the long tail of driver mutations in kidney cancer? Do those fall within common pathways that might actually lead us to better understand kidney cancer biology? What is the connection between the somatic alterations and immune infiltration? We saw some interactions between PBRM1 or deletions of 9p21.3, but again, are there others? And then finally, how do these intersect or interplay to ultimately impact response? So that's a large ongoing project, but I think the use of whole exome sequencing and RNA sequencing is really applicable to answer a number of other focused questions. And I think as we think about these, it's also important, we're really obviously tumor focused, but also to integrate what's happening in the host immunity as well. For instance, circulating soluble factors in the plasma or circulating immune cells as well. And so just a little bit of a hint of some of the things that we've been working on over the past year. One is a partnership with randomized McKay that should say UCSD, who ran a phase 2 trial of another immune therapy drug, atezolizumab plus bevacizumab. This was actually non-clear cell kidney cancer, less common variants. And what we could see by looking at circulating factors by plasma cytokines that there's actually a highly correlated module of inflammatory cytokines that are present in a variety of these patients with non-clear cell disease. And what we call the systemic inflammatory module, this was actually associated with worse response and worse survival within these patients. We've talked mostly about the genetics, but we know that the RNA sequencing can also be leveraged to really understand some of the molecular subtypes of kidney cancer. There was really nice work done from the Genentech group in work that was initially led by Bob Motzer and Brian Rini, where they broke down kidney tumors from a phase 3 trial in kidney cancer into different molecular subtypes, and actually were able to see differential response to therapies. It was actually predictive of whether a patient would respond to therapy A or therapy B, which is a really exciting sort of idea, biomarker-driven selection of therapy for patients with kidney cancer. However, that was from patients treated with drugs that are not FDA approved. It was overall a negative phase 3 trial. And so in work led by Renee Maria Salabi in my lab, we've actually used a random forest model to now classify tumors in a FDA-approved regimen, avelumab plus axitinib, and actually look at whether these are associated with response or resistance in a really FDA-approved regimen. Really, can you use this for treatment selection? The answer is probably not. And finally, we know that some patients, as I showed, not just respond to immune therapy, but really have exceptional response. They really have long-term durable response that goes on for years, or tremendous tumor shrinkage. And so how can we learn what might drive not just response to therapy, but exceptional response? And this is together with Suchet Shukla's lab at MD Anderson. We've partnered to look at a handful of these exceptional responders, both from cohorts we have, but also, again, in partnership with industry, and are able to identify certain features, the presence of high clonal neoantigens, and actually a higher proportion of tertiary lymphoid structures that really seem to be associated with these exceptional responders, ones that really have response that lasts for years. And so overall, our lab is really focused on using a lot of these classic genomic and transcriptomic tools to understand response resistance to therapy. But we know these are sort of broad tools, classic genomic tools, that to understand really what's happening in the tumor microenvironment and the tremendous heterogeneity, both in T cell phenotypes, but also in other cells with the immune system, we need finer tools, and that we've heavily relied on single cell RNA sequencing for this. And so our past work really asked a pretty basic question independent of therapy, which was, as you advance along disease stage, as you go from a relatively normal kidney, or at least non-malignant kidney, to early stage kidney cancer, to locally advanced kidney cancer, to metastatic kidney cancer, how does the immune microenvironment change? How do the T cells change? How do the myeloid cells change? And are there any interactions between them? And to do this, we had prospectively collected fresh tumor specimens from different patients with either early stage, locally advanced, or metastatic disease, and performed single cell RNA and TCR sequencing. Overall, we had a pretty good balance. We sequenced about 165,000 cells from a little over a dozen patients, heavily skewed towards sequencing the immune compartment of the microenvironment. And so now, armed with this data set, we can begin to ask questions. What did the T cell compartment look like, and how does that evolve with with advancing disease stage? And ask similar questions of the myeloid compartment. For the T cell compartment, we can see heavy infiltration by CD8 T cells. Largely, there's a huge component of terminally exhausted CD8 T cells, but we see a variety of T cell phenotypes ranging from resident memory-like cells to classic Tregs. And so when we classify these different T cell populations, these T cell clusters, and organize them in a way to see which might be increase in advanced disease stage, we begin to see highlighted in red that there are few T cell clusters, few T cell populations that really seem to be enriched in more advanced disease. Now, at least for me, it's a little bit unwieldy to look at so many different T cell populations. And so what we did was more broadly classify them. Just using standard hierarchical clustering, we can construct this dendrogram where transcriptionally related groups of cells are near each other on this dendrogram, and ones that are transcriptionally different are far apart. And what we can see is now, instead of 18 or 19 different clusters, we can see really two broad groups. In red, T cell, CD8 T cells that broadly have markers of T cell exhaustion, expression of TOX, high expression of multiple inhibitory receptors. and then everything else, all of the other T cells, which are shown in blue, the non-exhausted T cells. And now with this much more simplified definition, we can see a pretty striking pattern that terminally exhausted or exhausted CD8 T cells progressively increase with advancing disease stage. They're essentially absent in normal kidney, present in very low levels in early stage disease, and progressively increase in more advanced disease stages. And that we, by contrast, see relatively few non-exhausted CD8 T cells with an advanced disease stage. So that's the T cell compartment. We have this progressive exhaustion with advancing disease stage. What about the myeloid compartment? And for the myeloid compartment, it's often harder to put these cells into discrete buckets. For T cells, we label them as either a Treg or a CD8 T cell that's exhausted. We put them in sort of these discrete buckets or clusters. Myeloid cells, as we know, can exist much more along a phenotypic spectrum. And so for this sort of analysis, for this sort of continuous phenotype, using a trajectory inference analysis is a really nice approach. It doesn't force you to put things into discrete buckets. It allows cells to exist on a phenotypic spectrum. And so when we do that for our myeloid cells, we see actually this nice, interesting branching pattern, which I think recapitulates a lot of sort of known biology. We have classic monocytes at the root, and then branching either into non-classical monocytes on the left or into macrophages on the right. And if we look at where these individual cells are coming from, those myeloid cells that are present in normal kidney, I should say normal with a caveat, they're adjacent non-malignant kidney. So it's from a cancer patient, might not be totally normal. But we see that they're largely classical monocytes and non-classical monocytes, very few macrophages in these non-malignant kidneys. Now, if we look at myeloid cells from different tumor types, we see a very different pattern. The first thing that might catch your eye is there's many more macrophages. That's the right-hand branch, and across different disease stages, there's just a lot more macrophages than there are in normal kidney. But if we actually hone in on that right branch, we see again a different pattern between early stage disease, locally advanced, and metastatic. In early stage disease, those myeloid cells, those macrophages, are heavily clustering relatively early along that branch, relatively early in that bifurcation. By contrast, locally advanced tumors are kind of spread throughout that branch or spread throughout what we call pseudotime. And if you look at the metastatic tumors at the bottom, those macrophages are all the way at the end of that branch, all the way at the end of pseudotime. And so what are the genes and gene programs that are really driving these trajectories? It looks like a switch from a more pro-inflammatory state to a more I hesitate to use the term, but an M2-like state, an imperfect term, but a more immune suppressive or pro-tumorigenic state that we see if we look at signatures of pro-inflammatory signature. Those peak and are really high early on in pseudotime at that right-hand branch where those early stage macrophages are. And by contrast, if we look at an anti-inflammatory signature, that really peaks later, corresponding to where those metastatic macrophages are. If we look at individual genes, pro-inflammatory genes, IL-1 beta, TNF, IL-6, those are all relatively absent in those metastatic macrophages outlined in pink, whereas if we look at genes that are typically associated with this more M2-like phenotype, things like CD163 or the folate receptor, those are significantly enriched expression in those metastatic macrophages. I should say not shown here, those really do express high levels of complement genes as well, and TREM2, which has been described by other groups, these TREM2 positive macrophages. And so we've looked independently at T cells, independently at myeloid cells. The natural question is, are those independent events or are they actually talking to one another? And to begin to look at this, we inferred cell-cell interactions using the transcriptomic data. And the idea is fairly simple. We use a tool called cell phone DB. And the idea is if one group of cells is expressing a ligand and another group of cells is expressing the known receptor complex for that ligand, you might infer that they're interacting or talking to one another. And by randomly permuting the labels, you can actually get some statistics and say, is this something that we expect more than by chance? And what's shown here is a heat map of the number of interactions between different cell populations. And there's a couple different patterns you might see. There's the darker blue area. That's an area of relatively low number of cell-cell interactions between different cell types. And that's usually between different T cell populations. In red in the upper left corner, you see a lot of interactions, mostly between different myeloid cell populations. And then outlined in black was a particular area that caught our eye, which are a high number of interactions between T cells and myeloid cells. And when we zoom in and look on exactly what populations, it's actually these M2, like these TREM2 positive macrophages interacting with these terminally exhausted CD8 T cells at a high degree. So these are inferred interactions. We obviously have to make sure they're actually present in the same sample. They have to be in the same tumor to physically interact. And so we look at the relative proportion of these different populations. We can again see they're really highly correlated. There's a strong correlation between the presence of these CD8 T cells and these tumor-associated macrophage populations. And so what are these interactions? They appear to be interactions that are bidirectional and really support these different phenotypes. So these tumor-associated macrophages are producing ligands for inhibitory receptors on T cells, things we already know about and target, like PD-L1 and PD-L2 for PD-1, but things we don't yet target in kidney cancer, things like PVR and Nectin-2 for TIGIT, ligands for TIM3 and other inhibitory checkpoints. But it's not all myeloid cells inhibiting T cells. Those T cells, terminally exhausted CD8 T cells, are also producing factors like MIF or CSF1 that support this more M2-like polarization. And so it's really a bidirectional sort of immune circuit that seems to be present in advanced disease stages. This is, of course, all inferred from gene expression. So can we gain a little bit more confidence that this is true, this is real? And we have a couple of different validation exercises I'll briefly go through. One is, are these actually expressed at the surface, at the protein level in these different populations? And we can use flow cytometry to look at that. Are these actually present in the same tumors in physical proximity in situ within the tumor itself? And we can use multiplex immunofluorescence. And then ultimately, is this actually true, not just in this small discovery cohort, but also more broadly in other larger patient cohorts? And so briefly to step through, this was in partnership with Arlene Sharp's lab. We looked at these different terminally exhausted CD8 T cell populations and CD163 positive macrophage populations and asked the question, do the T cells express the ligands we think they should, or the receptors we think they should? And do the macrophages express the ligands we think they should? And the answer was yes, they do. And they're higher in advanced disease stages. Partnering with Sabina Signoretti's lab, performing multiplex immunofluorescence, we looked at whether these myeloid cells, these CD163 positive macrophages, were actually physically interacting in advanced tumors with these terminally exhausted CD8 T cells. And again, in multiple metastatic tumors, we can see evidence for in situ interactions. And then finally, looking at other external cohorts, we first looked at a previously published CyTOF cohort from Bernd Bodemiller's group and reanalyzed that data to specifically look for our T cell and myeloid populations, our CD163 myeloid populations, and again, could see this pattern where the proportion of these cells increase with advancing disease stage. And finally, we derived a gene expression signature representing that interaction between those myeloid cells and T cells and used that gene signature to interrogate the TCGA, and again, found this pattern of increasing signature of interaction with advancing disease stage. Now that we have this RNA-seq signature, we can actually ask the question, is this interaction signature actually associated with worse outcomes, with worse survival? And the answer was yes. If we look at the TCGA data, having a high expression of this TAM to T cell interaction signature was really associated with worse overall survival overall. But again, we have to be cautious. That might just be because it's enriched in stage 4 disease. And so if we look specifically at those patients with stage 4 disease in the TCGA, again, we see the same effect, having a higher number of those interactions associated with worse overall survival. And if we look at, again, our initial cohort, our checkmate cohort that we previously reported on, again, having a high expression of that interaction signatures associated with a worse survival. And so the model we would put forward would be that with advancing disease stage, we have this progressive T cell exhaustion, this switch to a more M2-like, this anti-inflammatory macrophage population, and that critically in advanced disease stage that they're really talking to one another. They're interacting in a way that we hope is therapeutically targetable. So up until now, I've talked broadly about kidney cancer as if it's one entity, but I've been sort of misleading you. It's actually many, many different diseases. And so what we've been talking about is really clear cell kidney cancer, which is shown here histologically, which is looks clear under the microscope where it gets its name. But in actuality, this is a host of over 20 different diseases with more entities being described each WHO update. And there's a huge proportion of, I apologize, should be about 25% non-clear cell, which is, it's always bad to be labeled by what you're not, but these are variant histologies of clear cell. The more common ones are papillary, chromophobe accounts for about 5%. rarer types, including translocation, and then hereditary forms, including FH deficient, really aggressive disease biology that often affects people in their 30s. And so while all of our efforts have been really focused on clear cell kidney cancer, and that's where a lot of the clinical data is as well, we know that these non-clear cell variants really are unmet clinical and scientific need. We really need to understand their biology and how to treat them, because most of the treatment is really extrapolated from our experience in clear cell. And so our first sort of approach to this is really in the chromophobe space. And so chromophobes really are along a spectrum of these renal oncocytic neoplasms that range from pretty benign tumors, renal oncocytomas, which virtually never metastasize. They really have limited genomic alterations. Chromophobe is on the other end. They are true malignant disease. They have multiple whole chromosome losses. And then there's also these emerging entities in between, low and high grade oncocytic tumors, which have variable potential to actually invade and metastasize. And so one of the key things about these chromophobe tumors is, unlike clear cell kidney cancer, these don't do well with immune therapy. And so there's always going to be exceptions, but both in clinical trial data of immune therapies where they've included chromophobe patients, the response rate is typically less than 10%. And if we look at these chromophobe tumors, this is our own data partnership with the International Metastatic Database Consortium, Danny Heng's group at University of Alberta. And we looked at now hundreds of patients treated with immune checkpoint inhibitors, real world data that are either clear cell or chromophobe, and the chromophobe patients really don't do well here. This is in sharp contrast to in other treatment varieties. Chromophobes typically actually have a better disease prognosis. And so really this is an area of unmet need. Why aren't chromophobe tumors responding to immune therapy? And so to begin to look at this, and again, these are rare tumor types, we were able to identify a handful of patients, about 5 patients that really represent this disease spectrum, and again, perform single cell RNA sequencing to look at the immune microenvironment and also the tumor and stromal components as well. And really our focus questions were, why aren't these responding to immune therapies? And going in, we had a couple of hypotheses. So one is maybe it's just a lack of immune infiltration. If you don't have cells there to begin with, then it's hard to get any immune response. The second is perhaps they're exhausted in ways that don't rely on PD-1. So perhaps these have some severely exhausted dysfunctional program that are really incapable of being reinvigorated by our current immune therapies. And the last possibility is maybe those are just bystander T cells, where they're not actually infiltrated by tumor-specific T cells that are required for true anti-tumor efficacy. And so with these sort of focused hypotheses, we can begin to look at these different areas and see which of them actually are applicable to chromophobe tumors. So the first is immune infiltration. Here we did very basic CD45 immunohistochemistry just to look at the immune infiltration, broad immune infiltration of these tumors. And what we can see is on the right, you see clear cell and the immunohistochemical stain for CD45. These are really heavily immune infiltrated T cell, immune infiltrated tumors, as we saw in our previous study. By contrast, these oncocytic neoplasms, oncocytomas, low-grade oncocytic tumors, chromophobe tumors, these have really low degree of immune infiltration. And we can see that sort of characterized statistically on the right. And so that seems to be one problem. There just aren't a lot of immune cells. So if we're going to improve immune responsiveness of these tumors, one will be driving immune cells actually into the tumor itself. The second is, are there cells that are there just too exhausted to respond? And to begin to look at this, we again turned to our single cell data and looked at the CD8 T cell populations and saw, did they express markers of immune exhaustion? And the short answer is no, those were not exhausted T cells. So if we look at clear cell, which is on the left, versus chromophobe on the right, we see, as we know, the ones in the clear cell tumors are often exhausted, terminally exhausted CD8 T cells. That was not the case for chromophobe tumors. And if we look now at the TCGA data, we see a very similar pattern, that chromophobe tumors have relatively low levels of exhaustion markers, expression of exhaustion markers, that's compared to clear cell disease. And so these are not exhausted T cells. They seem actually like they're cytotoxic. They seem like they should be functional, the ones that are there. Why aren't they actually doing the job? The last part is maybe they're not tumor specific. And so there's ways to formally prove this by actually TCR sequencing these, reconstructing those TCRs and testing for anti-tumor specificity. That's what needs to ultimately be done. Our first take at it is to use the single cell TCR data that we have to try to infer specificity. And we did this in two different ways. One is by taking those TCRs and mapping them to TCRs that have known viral specificity. Those are usually specific for things like CMV or EBV or flu, common viruses that have nothing to do with these tumors. And we can see that the T cells in chromophobe kidney cancer map to a much more significant degree to these viral specific, they have a viral specificity. So much more likely to be bystander T cells. The other approach we used was to take signatures, gene expression signatures defined by both Kathy Wu's group, but also Steve Rosenberg's group at the NCI that are signatures of tumor specificity, including neoantigen specificity, and see what that expression looks like in these different tumor types. And we can see for clear cell kidney cancer in red that those have a high degree of tumor specificity signature, and for chromophobe, that's substantially less. And so overall, this is our first sort of attempt to really characterize what is an uncommon, a rare tumor type, and really try to understand its immune biology. It looks like it has a lack of immune infiltration. It looks like the T cells that are there are probably fully functional, but lack a tumor specificity. So that's the work we've largely done, the work that was published last year and the work on chromophobe tumors that's been really over the past year. But now what we want to do is move from just characterizing the disease biology to really understanding how these different tumor microenvironments might impact response or resistance to therapy. And ultimately, how can we functionally evaluate these? How can we actually go from a laundry list of potential cell-cell interactions to ones that actually might be therapeutically targetable in the clinic? And that's really what the focus is. We've started this process, but over the next year. The sort of idea behind this is shown here. This is a perspective we published a couple of years ago now, which is to really try to integrate these tumor biopsies for fresh tissue collection for single cell RNA sequencing into clinical trials. And obviously this is expensive, this is technically difficult, there's feasibility issues. But if you could do this even for a handful of patients, a small discovery cohort, and really go into a lot of depth for a small number of patients, then you can actually learn some lessons like we did in our prior work and try to then use more conventional tools, standard exome sequencing, RNA sequencing, immunofluorescence, immunohistochemistry, then try to apply that to a larger validation cohort. And so this is our attempt. This is our basic schema that we try to take patients who are responsive or non-responsive to immune therapy. We try to get biopsies before treatment as much as possible. This is often challenging. We try to get biopsies on treatment or at least at progression, variable success on that. And then to perform single cell RNA sequencing to really uncover what are the cell type differences, cellular composition differences, phenotypic differences, and ultimately what are the differences in cell-cell interactions. And so we've been lucky, again, this is through partnership with a number of academic collaborators, but also industry collaborators, pairing to a number of phase 2 and phase 3 trials that we've been able to collect fresh tissue from a total of 96 tumors that were treated with immune therapy. And we've performed enzymatic dissociation, single cell RNA sequencing on these tumors, really to understand what is the difference in the immune landscape between responsive and non-responsive tumors. And we've, through a partnership with Akoya, begun to look at what is the orientation, the physical location of these tumor types, these different immune populations in space, using these high-dimensional platforms. This is an example of one of our tumors from a responsive patient showing actually a high number of tertiary lymphoid structures. And so is this actually feasible? Are we actually able to collect these cryopreserved specimens from different clinical trials and get viable cells out of this? So our first attempt at this was on a small number of patients, was just on 13 patients. This is a collaboration with Kathy still, with Mike Atkins at Georgetown, and with Kelly Street, who runs a computational group at USC, where we looked at the small number of cryopreserved tumors and said, are we able to get viable cells out of this? And the short answer was yes, that we're able to get actually really good representation of both tumor cells, immune cells, and also stromal components. And actually, even with this small cohort of ended up being about 13 samples that were suitable for analysis after passing quality control, we can actually begin to see are there differences in immune microenvironment between responsive and resistant tumors. And so again, this is a trajectory inference analysis. This time it's for T cells. And again, we see a branching structure, but here, a fairly interesting one that starts with a root of naive T cells and branches either into terminally exhausted CD8 T cells, those are the same ones we saw in our prior work across disease stages, or to these still having an exhaustion phenotype, but these SLAMF7 positive CD8 T cells. And when we look specifically at which immune populations are associated with resistance or with altered survival, it turns out that these SLAMF7 positive CD8 T cells, again, in this very small cohort, only 13 patients, was associated with progressive disease and with worse progression-free and overall survival. And so this is our sort of initial 13 patients. We're now parsing through the sequencing data from our 96 patients to really get a better handle on what are the different immune populations that might exhibit this sort of behavior. But we also have to move beyond immune profiling. We might get a sense of what are the immune populations that are relevant and what are the immune interactions which could play a role, but we actually have to nominate individual targets for the clinic. We actually have to be able to test this. And I think kidney cancer is a unique opportunity to do this. Part of it is just purely practical. These are enormous tumors. You can have a 6.5 centimeter tumor that's a stage 1 tumor. And it's not uncommon for these tumors to exceed 10 centimeters. And so there's just lots of material to be able to extract individual immune populations, individual tumor populations, and actually functionally test which interactions might actually play a role. And we've begun to do this. We've been able to take these primary tumors. And I should mention Kat Sidak in the lab is really spearheaded this process of identifying patients. This is in collaboration with Mike Hurwitz, who runs the GU Tumor Bank, with Debo Adeniran and Peter Humphrey in pathology and Pat Kenny in urology, where we're able to routinely, on just about every nephrectomy that's done at the hospital here, collect fresh tumor for this sort of work. And so we're able to extract both immune cells and tumor cells. And for a subset of patients, we're actually able to grow out tumor cell lines. And so this is really a valuable resource for thinking about autologous co-culture experiments with T cells. And so our sort of overall plan for functional validation is sort of two phases. One is a more reductionist approach, and one is one that maybe perhaps recapitulates the contacts of the 3D microenvironment a bit better. The reductionist approach, and again, this is led by a few people in the lab, Soki, Katrina, and Hannah, is to basically break this down into individual cell populations. So to associate those tumors into single cell suspension, isolate individual cell populations of interest, co-culture just those populations of interest with a therapeutic drug, with an inhibitor of a particular interaction, and then be able to measure changes in T cell function, basic flow cytometry for intracellular cytokine production, proliferation assays, expression of cytotoxicity markers like granzyme. And then we've begun to implement these model antigen systems where we have now T cells that we engineer with a specific TCR against NY-ESO-1 or against WT1. And we have tumor cells that express those antigens and express luciferase. And we can actually now test, have a model antigen system for testing these impact on cytotoxicity. Again, there's limitations of a reductionist model. And so in work that's done in collaboration actually now with AstraZeneca and a lot of mentorship from Marcus here, we also have begun to implement these tumor fragment models where we try to recapitulate the 3D microenvironment. We actually cut the tumor into these various fragments. We embed them in a collagen matrix. We float that in media where we can add various perturbants. And we can see that over the course of its short-term culture, 3 to 5 days, we really can recapitulate the histology, the architecture of these clear cell tumors, and preserve a lot of the immune microenvironment, both T cell and myeloid components. And so with this, we can actually use this to actually functionally validate some of these things. We've done some toy experiments. I'm showing one where we've added low dose or higher dose IL-2 and can show that we can impact the T cells that are there just as a initial sort of proof of concept. But now together with AstraZeneca, really looking at some of these interactions that we found in our original cancer cell paper, TIGIT and others, and seeing whether inhibition of those inhibitory interactions might actually impact tumor killing and T cell function. And so that second piece is really the tumor microenvironment and how that changes with advancing disease stage, and now how we can use that to understand response and resistance to therapy. The final aspect our lab focuses on is really trying to identify what are the relevant antigens in kidney cancer and how we might be able to therapeutically target them with antigen-directed therapy. And in order to do this, in my mind, we need sort of two pieces. We need a toolkit, an experimental toolkit to do this, and the other is we actually need the samples. And so the experimental toolkit is, I would say, both computational and physical tools. Computational tools includes better antigen prediction, the ability to infer not just neoantigens, but things like expression of endogenous retroviruses. Physical tools for antigen detection. These are immunopeptidomics, where we can actually immunoprecipitate off class 1 molecules from tumor cells, elute peptide, and actually physically detect the presence of individual peptides. This was done in collaboration with Steve Carr's group at the Broad. And then TCR tools, and these are now pretty established tools for single cell TCR sequencing, where we know the full alpha beta paired T cell sequence, but also the ability to then reconstruct them in primary healthy T cells and actually probe their specificity. So we do have a good toolkit for antigen discovery. Now we need the samples. And I think clinical trials, particularly early phase clinical trials, are a really wonderful platform to be able to do this really in-depth analysis. And so I'm going to give a little bit of a vignette of work that's wrapping up from my time at Dana-Farber. This is a clinical trial, a phase 1 trial that I led together with Tony Schwery and Patrick Ott of neoantigen vaccination in kidney cancer that I think has some interesting findings in and of itself, but really also serves, I think, as a platform for answering some of these questions. So this was a trial that took stage 3 or stage 4 patients with kidney cancer. They had to be fully resected at the time of surgery, so they had no evidence of disease, and these were clear cell only. And we treated 5 patients with vaccine or local ipilimumab, so a CTLA-4 inhibitor given at the vaccine site, or vaccine alone. And the basic process was we would take their tumor and then normal cells, we would take their blood, perform whole exome sequencing and RNA sequencing on the tumor. We'd identify tumor-specific mutations. We'd ensure that they're actually expressed at the RNA level. We'd use some of our tools that I just described to infer what are likely to be HLA binding peptides, so likely to be antigens. And then we'd actually get together in used to be in a room, then turned into over Zoom, but we get together as an epitope selection board to actually pick which are the mutations we want to target and design synthetic long peptides, anywhere between 20 to 25 mer typically, in order to actually physically synthesize them. We then partnered with a GMP peptide manufacturer to actually synthesize these peptides up to 20, representing different neoantigens, pooled that together with an immunoadjuvant poly-ICLC, and then that delivered that to the patient. We treated 9 patients overall. It's the sort of standard demographics you'd expect for kidney cancer. Majority were stage 3, though there were a couple stage 4 patients as well. And in every patient, we were able to identify enough mutations to actually target. So a median of 13 unique mutations were targeted per patient with 15 different peptides. Kidney tumors have a lot more frame shift mutations than a lot of other tumor types, so we're able to target a lot of frame shifts. And I think, interestingly, we're actually able to target in the majority of patients actually driver mutations within kidney cancer. And it turns out those, when we look back, ends up being the most immunogenic peptides, the ones that represent driver mutations. And I hesitate to talk about any sort of clinical data here, just because it's 9 patients, but they're at least encouraging. That it was certainly safe. Everyone did well in the trial, and there have been no clinical relapses. I would say in this population, probably at this point, somewhere around a third to half might have relapsed. And so the fact that there have been no disease recurrences is at least encouraging. But again, a big part of this was really the biospecimen collection. These were really generous patients that went through a lot for this trial. And so for each of these patients, and they went through the vaccination itself, which were 5 priming doses over the course of 3 weeks and 2 booster shots at week 12 and week 20. They had multiple skin biopsies prior to and after vaccination to look at whether the infiltrating immune populations within the skin. We obviously had the tumor tissue itself, but we needed lots of circulating blood cells as well to perform immune monitoring. And so we performed leukapheresis, often required a central line placement before and after treatment at week 0 and week 16, and pretty regular 200 ml blood draws. Regular 200 ml blood draws to really look at what are the circulating immune populations. And our questions were really trying to look kind of end to end, what's happening at the skin, as we move to the circulating immune system, and ultimately, are we getting tumor reactivity? It's nice to get reactivity against the vaccine itself, but if it's actually not impacting tumor reactivity, we haven't done too much. We haven't actually been helpful. And so just to briefly walk through this is what a typical, this is actually patient 1. So this is the prior vaccine scars and what the vaccine site looks like 2 to 3 days after vaccination. We can perform enzymatic dissociation, CD45 isolation, and single cell RNA sequencing, identifying really high populations of myeloid and lymphoid cells. And this is work in progress, but we actually see some fairly interesting changes in both the myeloid cell and T cell population. I'd say predominantly it happens with vaccination. We're not seeing huge differences with the addition of ipilimumab. Moving on to the circulating immune system, really the workhorse for this was interferon gamma ELISpots. These are taking peripheral T cells out of a patient, peripheral blood cells, putting them into a dish and stimulating them with the same vaccine peptides and seeing whether those T cells release interferon gamma as a marker of antigen reactivity. And we see at week 1 prior to vaccination, basically none of the neoantigen pools, the first 4 rows, had any reactivity, but we get pretty strong reactivity with vaccination. And that when we do flow cytometry and intracellular cytokine staining, we actually see that these are not largely polyfunctional, that they T cells not only produce interferon gamma, but things like IL-2 and TNF. And finally, moving beyond just vaccine reactivity, are we getting actually tumor reactivity? And so what we can do is, again, take some of these post-vaccine T cells, stimulate them with one of our vaccine peptides, in this case against a driver mutation, PBRM1, and then co-culture it with that same patient's autologous tumor and see whether those PBRM1 specific T cells actually recognize tumor. And the answer is yes, that we are able to actually get tumor reactivity. It's not for all patients, but for the majority of patients, we're able to get evidence of tumor reactivity with vaccination. And so really, this is our first sort of attempt at an antigen-directed therapy in kidney cancer. But I think neoantigens are a good place to start, but I think those are clearly not going to be the whole story in kidney cancer. We know that there's not an association between, as I showed, high neoantigens and response to therapy. So we have to look beyond this initial neoantigen-focused world and really look at other sources of antigens as well. And very briefly, this is work largely in collaboration with Bill Kalin's group and Steve Carr's group, where we're using the same cohort of patients, the same tumors, to actually look at endogenous retroviruses as potential antigenic targets. These are ones that are aberrantly expressed in a few different tumor types, but specifically kidney cancer has a high expression of these endogenous retroviruses. So we can, again, use our computational tools to predict antigens, potential ERV-derived antigens, and use mass spec-based approach to actually physically detect those antigens. And in this first patient, this is patient 110 from our original trial, we see that there were 7 ERV-derived peptides that were present on tumor, but not a normal tissue. And when we take one of those, the one highlighted in pink, and actually test those for reactivity in peripheral blood cells from that patient, we can see that that patient is actually capable of mounting a low level, but a response to that peptide. So just an initial proof of concept that these ERVs can actually be antigenic. And now we can actually do this much more systematically, look across all patients and all of their endogenous retroviruses that are presented and look for antigenicity. Again, these are very focused approaches. These are specific hypothesis, neoantigen or endogenous retroviruses. The last thing we want to do is ultimately build systems and collaborate with groups that are interested in more broad antigen discovery efforts for things that we're not thinking of. And so we recently entered a partnership with Remedy Bio, a biotech company based in Ireland, which has a novel platform, a nanoreactor platform that actually allows you to co-culture individual T cells and tumor cells within each of these wells, but actually measure which of those wells are reactive to tumors, use a pneumatic system to extract viable T cells, tumor reactive T cells, and be able to sequence their TCRs. So really be able to understand much more systematically what is the repertoire of tumor reactive T cells in kidney cancer. And so overall, our kind of hope with this branch of the lab is really to move beyond our classic tools for immunomodulation to add the steering wheel, rather than only looking at the inhibitory checkpoints or the sort of go signals for immune cells, to actually be able to add a component of an antigen-directed therapy, really focus on HLA-restricted antigens. And that's sort of the model for the lab. It's been a busy but a great year. That's been a wonderful time. I felt incredibly welcome here at Yale and been lucky to have a remarkably energetic and kind group of people join the lab, and really focus on sort of this model that we start with the patient. We try to learn things from their tumor, from their immune system. We have a lot to go and a lot of open questions about cell-cell interactions and about antigenic targets, but always with an eye to try to bring that into improved diagnostics, actually improve therapeutics, and try to bring that back into early phase trials, like I showed with our neoantigen trial. And then to continually iterate, to try to get a little bit better each time that we do this. And so with that, thank you again for the opportunity to speak. And a lot of people, both my lab and collaborators, but most importantly, the patients and their families. And if there's time, I'm happy to take some questions.
Just one question.
Yeah.
You showed that many of the vaccines are infiltrated by TDA. In general, you've shown that most of them are infiltrated by exhausted there must be some difference between responders and non-responders among that.
Yeah.
The question is, what is the difference in the CDA infiltrate based on responders and non-responders?
Within infiltrated tumors? It's a good question. I think that's where our sort of larger collection of this 90 single cell sequence of 96 tumors will, I think, be very helpful. If I were to answer this 6 months ago, I would have said it's going to be impacted largely by the myeloid component as well. And I think that still is probably true. That we kind of showed in our original study that even though we're thinking that we're measuring CD8 T cells, likely what we're actually capturing is interactions between those terminally exhausted CD8 T cells and the myeloid component, and that historically, we've only targeted one branch of that. We've only targeted the T cell compartment and not the myeloid compartment. I think that's going to be one big piece of it. The second piece, which we weren't expecting to find, is this particular phenotype of SLAMF7 positive CD8 T cells that requires a lot of validation, both that they're actually real, but then that they have a functional role. I think that's going to be the other sort of component. Are there different actually T cell phenotypes, even though they're broadly infiltrated by similar numbers of CD8 T cells? Are those CD8 T cells of a different phenotype that actually might be perturbable in some way? And one nice thing is there are even FDA-approved antibodies like elotuzumab for SLAMF7, so one can see actually a pathway of those end up being true to the clinic. So that's kind of ongoing work now. Actually, a rotation student in the lab is putting SLAMF7 into some of these T cells, and we're actually seeing whether this impacts cytokine production, proliferation, tumor killing. Oh, thank you.
And I know for the kind of page for fibroblasts or from the knowledge from how this goes, I mean, maybe you're coming to, any comment on that?
Yeah, it's a great question. So the question was just about the stromal component, fibroblasts and other stromal and kidney cancer, particularly endothelial cells as well, which these are heavily vascular tumors. I would say our first study we really didn't look at it at all because our protocol really enriched for immune cells. I think now with not only the chromophobe project, but also these larger 96 samples, we actually much more broadly capture cancer-associated fibroblasts and endothelial cells. I will say that first 13 patients, we didn't see any that were specifically associated with response or resistance in this very broad look, but that obviously doesn't mean they're not important for actually driving either T cell or myeloid biology. And so that's something that I think we need to look into in more depth, but we don't know quite yet. But actually now I think, yeah, now we actually have the tools to be able to look at it.
I think, it's fun because it's both, really the only tumor type that's both epidemiologically associated with obesity and commonly treated with checkpoint inhibitors. So I'm wondering if you have any hints in your data as to the role of metabolism in the microenvironment.
Yeah, it's a great question. The short answer I'll give is not yet, but I'd love to be able to sort of partner and look at it because there's some fascinating parts about kidney cancer as well. So there's something where even though you're more likely to get it, the incidence is higher in obese patients, those patients who are obese who have metastatic disease do better, something called the obesity paradox within kidney cancer. And we know that there's some hints that these are, in general, really metabolically active. There's really excellent work from Jeff Rathmel and Kim Rathmel's group that looked at what are the primary consumers of, for instance, glucose in the microenvironment. And it turns out it's not the tumor cells. It turns out it's mostly the myeloid compartment. That's the primary consumer, but T cells are still consuming a lot. How those actually ultimately, I think, impact the function of T cells, I think we haven't looked at it all, but it would be great to be able to explore, especially with some of these models where we're, have them in really nutrient-rich, metabolically favorable conditions ex vivo. Actually, it'd be nice to recapitulate some of the nutrient limitations that are present in the tumor itself. Yes.
Well, thank you, David. Thank you all for also coming here in person, and we'll look forward to grand rounds next week. Thanks so much.
Thank you so much.